Interpretation of diagnostic results in fertility. Understanding normal versus abnormal findings. When undergoing fertility evaluations, understanding the results of various diagnostic tests is crucial for diagnosing and treating infertility. Diagnostic results can include a wide range of tests for both male and female partners, assessing factors such as hormonal levels, ovarian reserve, sperm quality, fallopian tube patency, and uterine health. The ability to differentiate between normal and abnormal findings is essential for determining the most appropriate fertility treatment. 1. Male fertility testing. Interpretation of results. Male fertility testing typically involves a semen analysis, hormonal assessments, and genetic testing. Below is an overview of the normal versus abnormal findings for these diagnostic tests. Semen analysis. Semen analysis is the most common test for evaluating male fertility. The key components assessed are sperm count, motility, and morphology. Normal findings. Sperm count. Typically, a normal sperm count ranges from 50 million to 200 million sperm per milliliter. Sperm motility. 50% or more of sperm should be able to swim forward. Progressive motility. Sperm morphology. At least 4 to 14% of sperm should have a normal shape. Abnormal findings. Low sperm count, oligospermia. Less than 15 million sperm per milliliter is considered low. It can significantly reduce the chances of conception. Low sperm motility, astenosospermia. Less than 40% motive sperm can affect the sperm's ability to reach and fertilize an egg. Abnormal sperm morphology, teratozospermia. A high percentage of abnormal sperm shape, greater than 96%, can hinder fertilization. Severe abnormalities may lead to male infertility. Hormonal tests for male fertility. Hormones such as FSH, LH, testosterone, and prolactin are assessed to check for abnormalities that might affect sperm production. Normal findings. FSH 1.5 to 12.4 MIU per milliliter. LH 1.7 to 8.6 milli-international units per milliliter. Testosterone 300 to 1000 nanograms per deciliter. Prolactin less than 50 nanograms per milliliter. Abnormal findings. High FSH suggests primary testicular failure or reduced sperm production, poor sperm count. Low testosterone may indicate hypogonadism, low testosterone production, PE, which affects sperm production and libido. Elevated prolactin can lead to a reduced production of testosterone and sperm. Genetic testing. Genetic testing for conditions such as Y chromosome, microdeletions, or karyotyping can provide information about inherited factors that may contribute to infertility. Normal findings. Normal karyotype with no deletions or mutations affecting sperm production. Abnormal findings. Y chromosome microdeletions. Genetic mutations on the Y chromosome can lead to azoospermia, absence of sperm in the semen, or oligospermia. Karyotype abnormalities. Chromosomal abnormalities such as Klinefelter syndrome, double XY, can result in low sperm count or infertility. 2. Female fertility testing. Interpretation of results. Female fertility testing often involves hormonal evaluations, ovarian reserve testing, tubal patency testing, and uterine health assessments. Here's how to interpret normal and abnormal findings from these diagnostic tests. Hormonal tests for female fertility. Common hormones tested include FSH, LH, estradiol, progesterone, AMH, anti-Mullerian hormone, and prolactin. Normal findings. FSH 3.5 to 12.5 MIU per milliliter during the early follicular phase. LH 5 to 20 milli-international units per milliliter during ovulation. Estradiol 20 to 150 picograms per milliliter follicular phase. Progesterone 1 to 28 nanograms per milliliter luteal phase. AMH 1.0 to 3.0 nanograms per milliliter indicates a healthy ovarian reserve. Prolactin 2 to 29 nanograms per milliliter. Abnormal findings. High FSH, high levels above 12.5 MIU per ml may indicate diminished ovarian reserve or premature ovarian insufficiency, POI. Low AMH. A low AMH level less than 1 nanogram per milliliter indicates reduced ovarian reserve and may suggest fertility challenges related to egg quantity. Elevated prolactin. High prolactin levels can inhibit ovulation and menstrual cycles, potentially leading to infertility. Abnormal progesterone levels. Low levels during the luteal phase can indicate luteal phase defects, where the uterine lining does not support embryo implantation. Ovarian reserve testing. Ovarian reserve refers to the number and quality of eggs a woman has, which typically declines with age. Tests include AMH, FSH, and AFC, antral follicle count. Normal findings. AFC, 5 to 10 antral follicles in each ovary is a good indicator of healthy ovarian reserve. AMH, higher levels are indicative of a good ovarian reserve. Abnormal findings. Low AFC or AMH suggests diminished ovarian reserve, which may make natural conception more difficult. High FSH, elevated FSH levels greater than 10 milli-international units per milliliter indicate reduced ovarian reserve and may suggest a lower chance of successful conception. Tubal patency and uterine health tests. These tests are used to evaluate whether the fallopian tubes are open and the uterus is healthy enough to support pregnancy. Normal findings. Hysterosalpingography, HSG. Dye passes freely through the fallopian tubes, indicating that they are open and unobstructed. Hysteroscopy. Uterine cavity is normal with no fibroids, polyps, or adhesions. Abnormal findings. Blocked fallopian tubes, detected on HSG or laparoscopy. This can significantly hinder conception by preventing sperm from reaching the egg or the embryo from reaching the uterus. Uterine fibroids, polyps, or adhesions. These can affect implantation or lead to pregnancy loss. Hysteroscopy and laparoscopy are used to diagnose and treat these conditions. Laparoscopy. Laparoscopy is often used for detecting conditions such as endometriosis, ovarian cysts, and pelvic adhesions that may affect fertility. Normal findings. No signs of endometriosis, adhesions, or ovarian cysts. Abnormal findings. Endometriosis. Tissue similar to the uterine lining grows outside the uterus, causing pain and infertility. Ovarian cysts can affect ovarian function and fertility. Pelvic adhesions. Scarring in the pelvic area may block fallopian tubes or impair ovarian function. 3. Conclusion. The interpretation of diagnostic results in fertility assessments is essential for determining the underlying causes of infertility and choosing the appropriate treatment. For both male and female fertility, understanding the normal versus abnormal findings helps guide clinicians in offering effective interventions. By analyzing hormonal levels, ovarian reserve, sperm quality, tubal patency, and uterine health, fertility specialists can create personalized treatment plans, increasing the likelihood of a successful pregnancy. Key takeaways. Normal results indicate healthy reproductive function, while abnormal findings signal potential fertility issues that may require intervention. It is crucial to consider both physical and psychological factors when evaluating infertility. A holistic approach involving medical, genetic, and psychological assessments is often required to address fertility challenges effectively.